More and more patients are referred for the assessment of valve prosthesis, and Christine Ari will present how to evaluate mechanical valve in aortic and mitral positions in 2 different patients. She will start addressing the different echocardiographic parameters that need to be evaluated for differentiating normal from abnormal functioning of prosthesis. And she will end up these presentations by 3 different pathological cases.
Today I will show you how to evaluate a mechanical valve in aortic position. So this is a patient with a carbomedic number 25. So first we're going to start the exam as usual in parasternal long axis view. So here you can see the aortic prosthesis, and you can evaluate the movement of both leaflets. Here you can clearly see that both leaflets are moving symmetrically. You can also use the M-MOD to assess the movement of the leaflet. Here you can see the opening of both leaflets during the systole. After, you can put the color Doppler, and with the color Doppler you can assess the presence of significant leakage. Here you can see that there's some small leakage that are strictly normal and refer to the normal backflow closure. After, you can use the zoom mode, and with the zoom mode you can again assess the movement of the leaflet, but also you should measure the left ventricular outflow tract diameter because you will need it to calculate the effective area of valve with the continuity equation. It's really important to measure just underneath the prosthesis ring and not to mistake the inner edge of the prosthesis for the left ventricular outflow tract dimension. In fact, like I said, you should measure it just underneath the prosthesis. And it's really important to know that you cannot substitute the size of the prosthesis for the LVOT diameter because it's not a validated method. Now, we're going to switch to the parasternal short axis view. Again, you can see the movement of both leaflets over here with the zoom mode. And if you add color Doppler, you can see that there's no significant leakage, and you should search specifically for paravalvular leakage in that view. Then we're going to continue the exam in apical views. You're going to start with the 5-chamber view to open the aorta and to see the prosthesis. And after this, you can put the color Doppler and you can assess again for the presence of significant leakage. Here, you can see that there's 2 small leakages. They are symmetrical and they are small and really narrow. And this is the physiological regurg that you can see with a mechanical prosthesis. And it's a normal finding. I'm going to show it you more slowly. So here you see the 2 small jets, just one here and the other one over there. And here, just to show you again, those leakages just over here, they are small, they are narrow, and they are symmetrical. So after this, you're going to use the pulse Doppler wave to measure the stroke volume and the LVOT velocity time integral because you will need it to calculate the effective area surface with the continuity equation. So it is really important to put the sample just 1 centimeter above the prosthesis. If you put it too deep in the left ventricle, you will underestimate the stroke volume. And if you put it too close of the prosthesis, you will overestimate the stroke volume because you will interrogate the acceleration zone. So you really want to be just 1 centimeter above the prosthesis. And to trace the envelope, you will adjust the definition and change the sweep to 100 millimeter per second. And then you will simply trace your envelope like this. And you will obtain the stroke volume, just over here, of 90 milliliter, and the LVOT VTI of 23 centimeter that you will need in the continuity equation. Then you will interrogate your prosthesis with the continuous wave Doppler. Here you can clearly see the brief opening and closing of the aortic valve. And also you should note that this is a triangular shaped envelope and that it's an early peaking with an acceleration time really short, less than 80 milliseconds. And then you will need to trace the envelope of that continuous Doppler flow. To do this, you should adjust again the sweep at 100 millimeter per second, and you will trace simply the envelope like this. And with that trace, you will obtain the max velocity, the max gradient, and the mean gradient, and also the aortic valve velocity time integral that you will need in the continuity equation. Here you can see that the mean gradient is 11 millimeter of mercury. For aortic prosthesis, the normal is below 20 millimeter of mercury. And then you realize that we have everything to calculate the effective area surface as we measure the LVOT dimension and we measure the LVOT VTI and here the AV VTI. And using all those parameters, you calculate the aortic valve area of 1.9. And when you do this, it's really important to compare that value with the reference value that you can find in references articles. And for a carbomedic number 25, the reference value is 2 centimeters square. So you are in the normal range for that kind of prosthesis. Also, another parameter important to assess is the Doppler velocity integral. To calculate it, you should divide the left ventricular outflow tract velocity time integral by the aortic valve velocity time integral. And in that case, the Doppler velocity index was 0.48, which is normal. And our normal Doppler velocity integral is usually below 0.25. Here we're going to move on to the three-chamber view because it's really important to evaluate the Doppler finding in multiple view because you can have different velocity or different gradient because of the eccentricity of the jet and the prosthesis. So here, as before, you can see with the color Doppler the small, symmetrical, and narrow jet representing physiological closure backflow. And here again, the same, you see clearly those small leaks. And again, you put the continuous Doppler wave and you see clearly the brief signal over here of opening and closing of the mitral valve. You see the envelope with the early peaking and the triangular shape. You adjust again the sweep to 100 millimeter per second and you retrace again the envelope to assess the max velocity, the max gradient, and the mean gradient. And here in that view we obtain by the continuity equation an aortic valve area of 2 centimeters square, which is completely normal. Then you should quickly assess some important repercussion that you can find in the case of significant pathological leakage. You should assess the pulmonary pressure using the transtricuspid gradient. So simply, as you all know, you just take the max velocity of the continuous wave Doppler on the tricuspid regurgitation. You can also quickly assess the right ventricular function using the TABC with the M mode. And you could also assess the systolic velocity at the tricuspid annulus with the pulse wave Doppler and the tissue Doppler imaging, just like this. And also you should assess the left ventricular function. You should assess the diastolic inflow pattern at the mitral leaflet tips, just like this with the pulse Doppler, and you should measure the E and the A wave and the deceleration time, and also using the pulse wave Doppler at the mitral annulus at the septal and the lateral with the tissue Doppler imaging. You should assess the E and the A wave, and especially the E wave as you're going to measure the E on E prime ratio. So this is the same thing on the lateral mitral annulus. And then finally, you can just evaluate the left ventricular systolic function using Simpson biplane method or triplane. So this is how you should assess a mechanical prothesis in aortic position. In that case, you can appreciate that there was no significant leakage, only the normal backflow closure. You saw also that the gradient was normal and not elevated. And also, you saw that the aortic valve area was concordant to the reference value available in the literature. I will show you how to evaluate a mechanical prothesis in mitral position. Before to start the exam, it's really important to ask the patient for the height and the weight to calculate the body surface area, and also to take the blood pressure. So now we can start the exam. As usual, we're going to start the exam in the parasternal long axis view. Here you can clearly see that there's a B-leaflet mechanical valve in the mitral position. First of all, you need to assess the mobility of the leaflet. Here you can see the normal movement of the leaflet just over here. Then you're going to add some color to see if there's some obvious leakage. But as you see, it's more difficult with prothesis in mitral position because of the reverberation and the shadowing over the left atria. Before to move on to next view, you need to measure the LVOT dimension because you will need it in the continuity equation to evaluate the effective valve area. So here, as you know, we just measure the LVOT dimension. So we can move on to the parasternal short axis view at the mitral valve level. Here you can clearly see the normal movement of both leaflets. After this, we're going to continue the evaluation of the mitral leaflet mobility and the apical views. Okay, so here you can see the normal movement of the leaflet, and you can appreciate also the reverberation and the shadowing in the left atria. So we're going to do the same thing in 4-chamber view, in 2-chamber view, and also in 3-chamber view. You can see that in each view, we perfectly see the movement of the leaflet that are strictly normal in that case. After this, we're going to go back in the 4-chamber view, and we're going to have Doppler color flow. Here, you're going to try to evaluate for the presence of pathological leakage. But as I said before, it's really more difficult because of the reverberation and the shadowing. So again, in 4-chamber view, in two-chamber view and in three-chamber view. Then we're going to go back in four-chamber view to use the continuous wave Doppler toward the mitral prosthesis. Here on that trace you can see the normal brief signal defining the opening and the closure of the mitral valve. And then you will trace the envelope of that flow to measure the maximal and the mean gradient. For a better definition, you need to adjust the sweep to 100 millimeter per second. And then you can simply trace the envelope of that flow. And you're going to evaluate the max gradient and the mean gradient. Here, the mean gradient is 3 millimeter of mercury, which is really normal. In a prothesis in mitral position, you will expect to have a mitral gradient less than 5 millimeter of mercury. Also, you should note that we calculate the mitral valve velocity time integral of 48 centimeter, and you will use this in the continuity equation to calculate the effective valve area. And here I'm showing you the same thing in two-chamber view, just to remind you that you should interrogate the prothesis in multiple view to be sure that you get the maximal velocity. So here again you adjust the sweep to have a better definition of the envelope, and you trace, and here again we have a mean gradient of 3 millimeter of mercury. And then to go further with the evaluation, we're going to assess the left ventricular outflow tract flow, because you will need to trace this envelope to have the LVOT velocity time integral to complete the continuity equation. So here again, you adjust the sweep and you simply trace the envelope, and you're going to obtain the LVOT VTI of 23 centimeter, as well as the stroke volume and the cardiac output. So here you realize that we have all the parameters to calculate the effective valve area, which is 1.5 centimeters square. You need to compare that value with the reference value available in the literature. For a St. Jude number 27, you should expect a mitral valve area of 1.7 plus or minus 0.4. So you are in the range of normal value, and this is perfect. Another parameter useful is to assess the pressure half time of the mitral envelope with the continuous wave Doppler. You need to know that you cannot take the pressure half time to evaluate the mitral valve area, but you should follow the pressure half time between the different exams, and to be worried if there's an abnormal lengthening of the pressure half time with times. So here the pressure half time was 73 milliseconds. A normal pressure half time is less than 130 for a mitral prosthesis. And then you will quickly look at indirect sign of significant valvular leakage, because, as I said before, you can easily miss significant leakage because of the reverberation and the shadowing of the left atria. So if you have indirect sign of valvular regurgitation, you should order a transesophageal echography to localize the leakage and to do quantification of this leakage. So the indirect signs are a left ventricular dysfunction or a left ventricular dysfunction or a left ventricular dilatation. Here I just want to show you also the normal microcavitation that you can see with a mechanical prothesis in mitral position, which are the little bubble just over here going in the left ventricle. So to assess the left ventricular function, you can simply evaluate this in 4, 2, and 3 chamber view. Also, for indirect sign of significant leakage, you should assess the right ventricular function. You can do this by assessing the TAPSE with the AIM mode on the tricuspid annulus, and also the systolic velocity at the tricuspid annulus with the pulse wave Doppler and the tissue Doppler imaging. And you should, of course, assess for the presence of significant pulmonary hypertension using the tricuspid regurgitation with the continuous wave Doppler, and measure the max velocity to assess the transtricuspidine gradient. And you can that way estimate the pulmonary systolic artery pressure with the addition of the pressure in the right atria, estimate with the dimension and respiratory response of the inferior vena cava. So this is how we can assess a mechanical prosthesis in mitral position. In that case, you can clearly see the normal movement of both leaflets. You can see that there was no significant leakage and also not indirect sign of leakage. And also you can know that there was a mean gradient of 3, which is strictly normal, and aortic valve, a mitral valve area of 1.5, which is concordant with the reference value in the literatures. Now I'm going to show you 3 cases of pathological evaluation. So the first case, it's a mechanical valve in aortic position. This is a carbomedic number 21. Here, just when you look at the movement of the leaflet, you can see that just above the prosthesis, there's some hyperechogenic material over here that are a little bit strange. And then if you add the color Doppler flow over here, you can note that there's more aliasing and higher velocity that you will normally expect. And if you interrogate with the continuous wave Doppler, you can note that you can see the triangular shape, but the acceleration time is significantly longer than the normal one, which should be under 80 milliseconds. And also, if you trace that envelope, you will know that the velocity is very high, almost 5 meters per second, and also that the max and the mean gradient are really elevated. And if you move on to calculate the effective valve area with the use of the LVOT diameter and also the use of the LVOT VTI, you're going to obtain an aortic valve area of 0.6, which is really smaller than what you should expect for that kind of prosthesis. So clearly there's something going on in that prosthesis and you should suspect a dysfunction. And in that case, when we use 3D imaging, we can clearly see over here that there was pannus just above the prosthesis, and that patient was referred to surgery, and the surgeon confirmed that diagnosis. So now I'm going to show you the second case. This is a patient with a mechanical prosthesis in the mitral position. He presented in the emergency room with symptoms of abrupt heart failure. As you can see here, it's really easy to see that the movement of the mechanical disc are not normal. When you use zoom mode, you can see that that disc is moving, but the other one over here is completely fixed. And moreover, you can see that strange structure over here that can correspond to a thrombus or a vegetation. When you put the color Doppler flow on that prosthesis, you can note that the diastolic inflow is going through only one orifice, and also there's a lot of aliasing and high velocity. And as we expect, when we interrogate that prosthesis with the continuous wave Doppler, you can clearly see the big envelope. And also you can see here that there's a click missing just for the opening of the prosthesis. And when you trace the envelope, you can clearly see that the mean gradient is really elevated with 33 millimeter of mercury. And as we measure everything we need for the continuity equation, you can assess the effective valve area, and it's really low actually with 0.5 centimeters square. And also another important parameter to assess is the pressure half time. You see here that the pressure half time is really long with a value of 356 milliseconds. So it's really above the reference range, which should be less than 130. And also you have indirect sign of mechanical valve dysfunction. Here you can see the septal movement first that correspond to probably a severe pulmonary hypertension. Also using the transtricuspidine regurgitant jet, you can measure the transtricuspidine gradient, and with the measure of the max velocity, you obtain a transtricuspidine gradient of 51 millimeter of mercury, which correspond to pulmonary hypertension. So now let's move on to the third case. Here, this is a young patient of 16 years old. She received a mechanical prosthesis in the mitral position when she was 8 years old. So this is a really small prosthesis. It's a Carbomedic number 23. And the patient present progressive dyspnea since 1 year. Here you can see when you assess the mobility of the disc, the mobility is strictly normal. And if you use the zoom mode, you can see that when you look at that prosthesis, it seems to be completely normal. But when you put the Doppler flow over here, you can see the aliasing and the high velocity. And when you interrogate the prosthesis with the continuous wave Doppler, you can note the really high velocity. And when you're going to trace the envelope, you know that the mean gradient is almost 12 millimeter of mercury, which is above the normal. The normal should be less than 5 millimeter of mercury. And if you use the continuity equation with the left ventricular outflow tract diameter and the left ventricular outflow tract velocity time integral, you can calculate the mitral valve area of 1.1, and the reference value for that kind of prosthesis is 1.3. So it's in the normal range for that kind of prosthesis. So now what you need to assess is the indexed mitral valve area. So to do this, you need to divide the mitral valve area that you obtain with the continuity equation by the body surface area of the patient. And in that case, if you do so, you will obtain an indexed effective valve area of 0.59. So you're facing a case of severe patient prosthesis mismatch. For a mitral valve prosthesis, you have a severe prosthesis mismatch when the index effective valve area is under 0.9. And for an aortic valve prosthesis, you have a severe mismatch when the index effective valve area is above 0.65. Then This is the three cases I want to present you to illustrate the pathological feature that you can obtain when you assess a mechanical prosthesis.
What are the take-home messages? First, when you assess a patient with valve prosthesis, you need to know the type of prosthesis. You need to measure the blood pressure and to evaluate the body surface area. Secondly, you need to use multiple echo Doppler windows. You need to evaluate and report the physiologic leaks, and you need to report the highest velocity, the mean pressure gradient, and the effective valve area.